two very interesting sessions lined up today. The first session is an invited talk by Professor Nitin M. Nagarkar. He doesn't need any introduction, and but for the sake of Kurt, we'll be introducing him, and Professor Saurabh Varshney will be introducing Professor Nitin M. Nagarkar. And the second session is a panel discussion on salivary gland cancers, which will be moderated by Dr. Shilpi Sharma, and we have an array of luminaries and the panelists who will be discussing the controversies in the salivary gland cancers. So with this, I hand over to our president, Professor Harish Taneja, for his introductory remarks. Dr. Taneja, please.
Good evening, everyone. I welcome you all, and I will not take much time. I want that session to start. Dr. Vipin has already introduced about the chairperson and the speakers. So I hand over to the chairperson, Dr. Saurabh Varshney, who is CEO of AIMS Dev College, who is Director Professor and Unit Head. To Dr. Saurabh and Dr. Ishwar.
Thank you, sir. Thank you, sir. Good evening to one and all. It's my pleasure to be a part of this important session. I know that Professor Nagarkar is very lucky to be operating, at least having an operating hand at Raipur and Bhopal, but I am right now for the last more than a year. I'm not in contact with knife, so that is bothering, but it's my great pleasure to introduce Professor Nitin Nagarkar, sir, who is a graduate from Patna Medical College and has done his post-graduation from PGI Chandigarh. Did his senior residency from PGI Chandigarh, had a very wonderful academic and contributing period at GMCH Chandigarh, where he was professor and head of unit and worked as medical superintendent there. And then he took over the reins of AIMS Raipur from the very beginning. And he has developed AIMS Raipur as one of the best centers of the country. And right now he's holding additional charge of AIMS Bhopal. We all know him as a very, very nice gentleman and a human being. But he is much better surgeon, what we know, because he is a very, very well-skilled head neck surgeon. And he will be talking about surgical management of parotid tumors, tips and tricks. I think tips and tricks can only be discussed by masters, and he is one of them. So we are very fortunate to have him and talking about some very practical tips about surgical dissection of parotid gland. So you're most welcome, sir. Sure.
Thank you very much for the very kind introduction, Professor Saurabh Varshney, my very close friend and colleague for so many decades now. We spent a long time together. Thank you, Professor Taneja, Professor Vipin Arora, Professor Ishwar Singh. I see a galaxy of people who have already joined us. I've got my faculty members and resident doctors from AIMS Bhopal, Raipur, and other institutions. Thank you, Dr. Vipin, for organizing this wonderful program, Academic Feast here today. I'll share my screen, please. So thank you very much. Yeah, thanks so much. So my introduction, Dr. Varshney has already given. Slide. Yeah, thank you. So again, thank you very much for this particular invitation here today. And the topic is an interesting one: surgical management of parotid tumors, tips and tricks. So I think all of us know that we as surgeons have to have the heart of a lion, nerves of steel, and the vision of an eagle, a very sharp and meticulous eye for detail, and a memory of an elephant. I think that applies for all surgeries, especially related to ENT head neck surgery, and more so, I think, for parotid surgery. So the salivary gland neoplasms, they are actually a group of neoplasms. We as ENT head neck surgeons or those working in larger institutions would get them as referrals, but otherwise they may not be so common as far as the general practitioner is concerned. But for referral centers, yes, you would get the referred cases, which are the rarer ones as well. It comprises a diverse histology, sometimes with an overlapping histology, like in cases of a pleomorphic adenoma, for example. You get the epithelial as well as the mesenchymal components, a variable clinical course. You can have a benign disease which is more aggressive. You can have a malignancy which has a relatively indolent course. So the presentation, if you're talking of the salivary gland tumors, because before I'll actually go to the surgical management, quickly I'll go to some very important clinical aspects which are going to help you in your clinical and surgical management of these cases, especially the parotid tumors. Most often it's an asymptomatic lump, usually long-standing, mobile, maybe cystic or maybe even firm areas in the same mass. Occasionally, if it's a large tumor or if it's arising from the minor salivary glands, you can have an intraoral bulge, or if it's gone into the parapharyngeal space from the deep lobe. But there are some sinister signs. For example, if the tumor has been present for so many years, but last few months has grown very rapidly, there is pain, involvement of the facial nerve, involvement of the skin, a trismus, which has caused difficulty in mouth opening. So all these would suggest that possibly it's a malignancy. I think the younger resident doctors should definitely make a note of this. We come across these kinds of swellings very often. You'll have a localized swelling somewhere situated in the tail of the parotid, a very common site over here. And you'll find this lady who has come with 3-4 years swelling present in this particular area. Sometimes we come across even younger patients who will come with a very short history, and very rapidly this mass has grown. And you can also see the skin has been stretched, it is shiny, and the skin is partly even given away with ulceration and some fluid also dripping out of it. Sometimes these patients have already been operated outside and maybe a few years ago or many years ago, and they also have a nodule somewhere in the previously operated scar, and the patient has again come to us possibly with recurrent swelling. And sometimes these are the benign lesions, the pleomorphic adenomas operated many years ago. We come across these kinds of patients also, again, large masses, extensive skin involvement, and all occurs in a very short duration, and patient usually goes to the local practitioner. Patient, by the time it reaches a larger center, few weeks or months have elapsed, and the tumor increases in size. Sometimes the lesion is small, but yet has already ulcerated into the skin, and that is a reason why we have to do proper radiological workup apart from FNAC, which I'll be coming to. Quickly, I'll mention that there are so many series which are there. There was one, this is the one which is mentioned in the British series, in the International Journal of Pathology, a large series where the bulk were parotid tumors. And they found that of those bulk also, it was the pleomorphic adenoma, which was the commonest. I think this has been the finding everywhere, that if we go across the site, it is of all the sites, whether it's the parotid, the submandibular, or the minor salivary glands, it is the parotid, which is around 70 to 80%. And of those also, if we see the bulk of them happen to pleomorphic adenomas. But the percentage for benign and malignant varies in cases of the minor salivary glands, where the percentage of the malignant tumors is more than the benign lesions. So there was one study, like you mentioned, Professor Vashni mentioned, this was my original series in GMC Chandigarh in 2004, published in the Indian Journal of Otolaryngology Head Neck Surgery, where it was 36 patients, of which 24 were parotid. And of those parotid also 19 were benign and 5 were malignant. So I think over the years, this was almost 18 years ago, things have almost remained the same. But yes, more and more patients do come to us because more and more diagnoses are occurring in the periphery. Facilities for radiology and FNAC now available, I think, in more centers than ever before. So fine needle aspiration cytology remains very important to make an initial diagnosis, because that is what is going to actually decide the type of the surgery that you have to perform. As I mentioned, sometimes a slowly growing mass actually is a pleomorphic adenoma, might actually present something like a slow growing malignancy also might present similarly. So the FNAC is the only clue for us at that moment in time. Of course, the gold standard remains the histopathology, but you will get it later on. But I think the centers have evolved, and the sensitivity and specificity has definitely now becoming now between 80 and 90%, and I think they're going close to more than 90% now, especially in those centers dedicated to these kinds of lesions. Ultrasound is also done as one of the preliminary investigations. may not give sufficient information alone, but it can be combined with fine needle aspiration cytology, especially, should know from which areas to take the aspirate. There are occasional intraparotid lymph nodes also, which might be picked up, but certain other conditions, for example, about the facial nerve or the depth or involvement of surrounding structures may not be so well appreciable. So you need to definitely do other investigations like an MRI scan or a CT scan. MRI scan is definitely very useful, and especially with the diffusion weighted images. We have good sensitivity and specificity now, has become one of the important first lines of investigation. CT scan also used to be done more often in the past, I think, but would show better for bone erosion and skull base involvement in those kinds of lesions. But soft tissue is definitely demonstrated better in MRI to show the tumor characteristics, extent, invasion, involvement of the retromandibular vein, and more importantly, whether it's going to the parapharyngeal space and lymph node involvement. So as I said, the commonest are the benign tumors, and of those, again, pleomorphic adenoma, Wardens are the commonest of those. Then we have got the malignant tumors. Again, a varying series are there. But if we see the parotid gland, the commonest malignant tumor in the parotid is the mucoepidermoid carcinoma. In certain series in the minor salivary glands, the commonest malignancy was adenoid cystic carcinoma. But I think overall, if we see, the commonest malignancy is mucoepidermoid carcinoma. So these are various series. Again, this is a series in the British Journal Oral Maxillofacial Surgery by Ryan et al. And quickly, if we see, there are broad clinical pathological categories of low, intermediate, and aggressive. And that is what is important, that we should know which one is the low grade, which one is the high grade and aggressive, because our management is going to depend on that. Just an example is actinic cell carcinoma, which falls in the low or indolent grade, or the low grade of the mucoepidermoid carcinoma, adenoid cystic carcinoma. On the other hand, you've got the aggressive type, the carcinosarcomas, and the high grade adenocarcinomas, which will grow very rapidly in a short duration. So now coming with this background, very important, because only then you'll be able to decide what type of surgery will be most suitable for your patient. It is best to have a tumor board. You can also have your radiologist, your cytopathologist sit along with you. And with your clinical examination, FNAC and MRI, I think you'll have quite a close to the final diagnosis you can come. There are different types of parotid surgeries, because I'll restrict to parotid surgeries. Partial superficial parotidectomy implies just a resection of the tumor with a small cuff of normal tissue wherever possible. It can be done for smaller Wardens. It can be done for a limited lesion of the parotid, which is basically a pleomorphic adenoma, less than say 2 centimeters or 3 centimeters in size. But you have to have an adequate cuff, and you have to have the expertise to be sure that you've removed adequate tumor along with an adequate margin. The gold standard has been, because the bulk of the lesions, as I mentioned, in the parotid also would occur mainly in the superficial lobe, around 70 to 80%. And superficial or lateral parotidectomy, therefore, is the commonest surgery which would be done in most of these cases, and would actually require removal of all tissue which is lateral to the facial nerve, because it's an artificial lobes that we have created. All tissue which is lateral to the facial nerve is the superficial lobe, and all tissue which is medial to the facial nerve is the deep lobe. Otherwise, we have the total conservative parotidectomy, where you remove most of the tissue, lateral as well as medial to the facial nerve, but preserve all the branches of the facial nerve. Radical parotidectomy, especially in malignancies, where you have to remove part of the entire facial nerve, as the case may be. And extended parotidectomy, where along with the radical, you would also like to remove the neck nodes or even skin, as you have seen in some of the photographs, where skin is involved or bone is involved, or joint, muscles, part of the inferotemporal fossa, and of course the lymph node clearance. So there's an extended parotidectomy mainly done for the malignant lesions. Of course, we'll take up all these cases under general anesthesia. Very important that we avoid long-acting paralytic agents, give a short-acting one, so that you can check for the movement of the near the angle of the mouth and near the eye. So that is important while actually performing the surgery, to check for any movement and flickering. So head and thorax end should be elevated by 20 degrees to reduce the venous congestion. And we rotate the head to the opposite side, extend it slightly. And you can also tilt the table by 10 to 15 degrees, making it convenient for the surgeon. Most of the time, the surgeon is seated as per comfort. And first, we locally give saline adrenaline for hydrodissection at the site of the incision. Minimal shaving is required, or hardly any shaving, especially in the ladies. You can just make a hair knot and take the hair away. eye ointment and eye taping is of course done, but facial muscles will be exposed. Now, whether intraoperative nerve monitoring is required, well, most of the surgeons would generally not require it. Visual cues are more than adequate most of the time. But if it's a resurgery or too much of scarring is over there, or it's a bulky tumor, then of course it can be an aid. But definitely it's the visual impression that the surgeon has, and looking for the facial nerve very meticulously is most important. Different incisions have been described. The commonest one, of course, is the modified Blair's incision. And this incision starts superiorly over here in front of the tragus and gradually goes down into the neck. Some take it even behind the tragus. So different modifications are there. It can also be a part of the facelift, like the Paratradectomy incision, which is done mainly by the plastic surgeons. And you can also go down into the neck and combine it with a neck dissection as well. One area of concern used to be this particular part, where the posterior part occasionally undergoes necrosis if it is a longer section and if it is less than 2 centimeters. So try to keep it shorter and broader, and you take a gentle curve down here. It gives a good scar, and the chances that necrosis of the skin will occur over here are then much lesser. And of course, Paratradectomy incision, as I said, we'll be just coming to that part also. The chances of Frey syndrome or having a thin flap are reduced by having this kind of an incision, and the scar is also pretty hidden in this particular case. So suppose the patient has already been operated before, then you can include the scar in your incision so that the scar finally comes out much better. I've already told about this incision and the necrosis which occurs in the postoral part of the skin. Paratradectomy incision can be used. Now, flap elevation is important. I'll show the photographs as well. We are superficial to the superficial musculoepineuritic space, the SMAS, and superficial cervical fascia. Hydrodissection helps us, but have a good plane of dissection, and it's usually an avascular plane. So we can very rapidly go anteriorly and develop a good area for the dissection to be conducted. Most of the time we remain superior to the SMAS adipose tissue. There's less bleeding, and chances of injury to the facial nerve branches is also lesser. Yes, sometimes there are surgeons, as I mentioned, who go deeper to the SMAS. The flap is thicker, has better vascularity, lower chances of Frey syndrome, but the chances of paralysis or injury to the facial nerve are more because the branches run in that area. So this is how we elevate the flap. You can see the SMAS, you can see the flap has been gradually raised up. There's a bit of adipose tissue over here. So the flaps are raised in the subcutaneous adipose tissue. We avoid injury to the hair follicles again, because if the injury of the hair follicles occurs, then there are chances of Frey syndrome in the postoperative period. Especially if the skin is thin, avoid buttonholing. Identify the greater auricular nerve early on in the dissection. You'll be able to see the greater auricular nerve. I'll show it in the other photographs also. And generally, it will divide into 2 branches. There's one which goes anterior toward the parotid gland, and the one which goes to the lobe of the ear. We preserve the one which goes to the lobe of the ear so that the sensation of the lobe of the ear is also preserved. And keep palpating the tumor and ensure, especially tell your whoever assists you, that be careful with the retractor. We don't want any tumor spillage to occur, especially with the sharp edge of the retractor. I don't usually take monopolar. I avoid usually monopolar because of the heat and the possibility of injury. Bipolar is absolutely fine. We remain parallel to the nerve, and don't go too anteriorly when you raise the flap. Otherwise, the branches of the facial nerve gradually from deeper, they start getting more superficial, and that's the chance when injury might occur. You may not realize it. So usually do that much of flap elevation has to be comfortable that you can access the entire tumor, especially related to the whatever is the size of the tumor in that particular case. Now, the posterior part of the gland dissection is important, where you have the sternocleidomastoid muscle and the posterior valley of the digastric. As I said, the greater auricular nerve, you preserve it definitely, and so that the sensation is preserved. Try to avoid ligation of the external jugular vein and the retromandibular vein, because that increases the venous congestion. And of course, it's also used as an important landmark sometimes. It's for the marginal mandibular nerve. So we generally keep it. So just quickly showing, this is the mass over here, and this is the standard incision that we make. And you'll usually find a skin crease over here. You can take the lower part in the skin crease, and that gives a very good cosmetic scar subsequently. Sometimes, as I said, there's a lot of skin involvement, and then you'll have to modify your incision, taking that into consideration as well. So We remain superficial to the SMAS plane. No hair follicles are seen. We have preserved the greater auricular nerve. Over here, it's going up. You'll find the branches as well. You preserve the branches which go to the lobe, and there's adequate exposure. The tumor is situated over here. So be careful when you go more anteriorly. Next is to dissect off the gland from the external aortic canal cartilage. And there's a parotid fascia which joins the TMS over here. And that's known as the Lorenz fascia near the temporomastoid suture line. And that you can go up to that fascia level. Good exposure and excellent hemostasis is very important. You tell your anesthetist about that. And they also reduce the blood pressure. They also reduce the heart rate. Retract anteriorly so that the flaps are well developed. And you can suture it also gently so that your hands are free. And fine dissection with bipolar cautery wherever required for the fine vessels and liberal saline irrigation. The next thing is if you see a bleeder just next to the facial, just keep a gauze and wait for some time. Definitely most of these bleeders will stop. And then as required, you can use a fine bipolar with lower setting. So this is the gland which has been dissected off now, the external aortic canal. Hemostasis is important. There are certain important landmarks, as I mentioned, to now identify the main trunk of the facial nerve. Posterior of the digastric muscle is very important, and the digastric muscle should be followed superiorly to the digastric groove, and that will actually lead to the facial nerve. So it's just above that on the superior border of the digastric muscle. Tragal pointer, yes, historically described Connolly's pointer, but it's a cartilaginous pointer. And while movement, the cartilaginous pointer moves. Historically mentioned, the facial nerve is one deep and slightly anterior inferior to the tragal pointer. But yes, it's not a fixed landmark. One very important one is, of course, the tympanomastoid suture line, and you'll find a nerve variable about 4 to 8 millimeters deep to the inferior end of the tympanomastoid suture line. It's a bony landmark and a fixed landmark, and I think one of the most reliable landmarks is the tympanomastoid suture. But sometimes you have a patient who has already undergone a surgery before, and then you can go retrograde. You can use the marginal mandibular nerve to go retrograde. You can use first the retromandibular vein just above that, superior to superficial to that. You'll find the marginal mandibular branch of the facial nerve, and then you can track it back to the main trunk. We have to do it occasionally. Most of the time, we'll follow the standard practice of identifying the trunk as I've already described. Occasionally, a mastoid approach where you have to do the drilling, and that's the occasional cases when destruction is more. Buccal branch also can be used. The styloid process is usually deeper to the facial nerve, so that doesn't work so well. And then this is how the various branches are. You've got the main trunk, then the cervicofacial and the temporal facial trunks, then the temporal zygomatic upper buccal from the cervicofacial trunk, and from the temporofacial trunk, you have the lower buccal, marginal mandibular, and the cervical branches. So these are important points I have to mention, that the nerve enters the parotid between the digastric and the stylohyoid muscle, and it divides into the temporofacial and the cervicofacial divisions. And the nerve is superficial distally, but innervates the muscle deep to the muscles. It's usually deep to the muscle, but as we go more peripherally, the nerve is actually more superficial. Be careful while traction is being applied. Use saline liberally, and large tumors are likely to displace these branches and make them more superficial, or also splay them. Even the upper end, the main trunk, the upper trunk and the lower trunk also might, that might be, a big gap because of the tumor over there. You have to be careful. So first of all, there is a variable anatomy of the facial nerve. And the second thing is that the tumor itself is going to make it more variable, or previous surgery if the patient has undergone that. Stenson's duct, some do ligate it, but others leave it in place, especially if it is from the deep lobe, expecting that the chances of post-operative paratradectomy fistula would be lesser. So I'll just quickly show some photographs. These are, like I was mentioning, if there is a large tumor somewhere in between the upper trunk and the lower trunk, that is the temporofacial and the cervicofacial divisions, then you will find this splaying which has occurred. So you can see the main trunk which has come from here, and rather than a 90-degree division, this is the lower trunk and this is the upper trunk. So these kind of variations will occur. Facial nerve monitoring during paratradectomy, there are so many studies. Obviously, some people suggest that for resurgeries, it is possibly better, but I think it's the surgeon's identification of the nerve carefully, which is much more important than anything else, visual cues. So I'll go quickly to a few types of surgery. Superficial partial paratradectomy. Now, this is a 17-year-old male. with a 3-year history of a right parotid swelling, small swelling 2 by 2 centimeters, and originally reported as pleomorphic adenoma. As you can see, the MRI shows a small lesion, just limited to the tail of the parotid. So we just decided to go for a smaller, procedure but with an adequate cuff. And this was the small lesion over here, around 2 by 2 centimeters in size. We were able to excise it completely with an adequate cuff of tissue. But the final histopathology was reported as Wardin's tumor, and the facial remained intact and patient is doing well. Superficial paratradectomy, as I said, the bulk of the cases are actually going to fall into this category. And this is a 36-year-old female with a 2-year history of a left parotid swelling, around 3 to 4 centimeters in size in the superficial lobe of the left parotid gland. FNAC was Milan category 4A, pleomorphic adenoma. And as you can see, the incision and where the tumor has been marked here. And the flaps have been elevated. You can see that this is the area of the tumor and this is the tragus. Now the hands of the surgeon are also free. We have raised the flap. The field is dry. You can see now the facial nerve trunk is now visible. We have used, as I said, the landmarks which I have mentioned. Now we go to the next, where the lower trunk is seen, and we are freeing the parotid gland from the lower trunk. Then we can continue the dissection, which is very important. You have to create tunnels. And then after every time you create a tunnel, you remain superficial to the branch. And with a 12 number blade, you cut the parotid tissue, taking care that you are away from the tumor. So gradually from inferior, we are moving up superiorly, taking the tumor as well as the normal parotid gland cuff. And you can see that gradually we are now going to come to the upper part of the lesion. And then now this dissection is complete. You can see the main trunk. This is the upper trunk with all its branches, the lower trunk with all its branches, and they have been preserved very carefully. You can also see the external carotid artery. You can see the retromandibular vein. So all this is done very carefully. All these branches are seen. The greater auricular nerve also, which we have preserved, as I said, which is going and supplying the lobe over here. So these branches have been preserved. And this is the tumor with adequate cuff of tissue. And this is the wound. We generally keep a drain most of the time so that the chances of saliva collecting within the flaps are lesser, and remove it after around 2nd or 3rd day. So this is the post-operative image. As you can see, the scar is very well hidden. And later on, there's another patient which shows a good post-operative result after 4 weeks after similar surgery. Now I'll just go quickly to a transparotid deep lobe tumor excision. I'm careful of the time, and I think in 5 minutes I'll just show those images and clear it off. So this is a 55-year-old male with a 4-year history of a left cheek swelling, and MRI showed almost a 2 by 3 centimeter benign tumor of the parotid. Even on MRI, you can get the clue, and FNAC was Milan category 4A. As you can see, the bulk of the tumor is mainly near the deep lobe part. Here also you can see this is the cuff of the normal tissue basically, and this is the tumor, and this is actually just entering into the parapharyngeal space. So this is the incision which is marked. Again, the dissection which has started, flaps raised, and we have started. This is the greater auricular nerve. This is the facial nerve, and now you can see this is the tumor which is seen, the pleomorphic adenoma, and it's being separated. We have also removed the superficial cuff of the parotid gland already. So that is one way of doing it. So this you can see the main trunk with all its branches again, which are preserved. And this is a sliver of superficial lobe of the gland along with the deep lobe tumor completely removed, and no facial paresis postoperatively. Occasionally you will have to do radical paratradectomy. Now this was a 12-year-old cheek swelling, which was gradually increasing. And now immediately the last few months has grown very rapid. And Milan showed suspicious for mucoepidermoid carcinoma. And you can see here, it's a large bulky tumor seen on the MRI, as you can see over here also. Still the facial nerve is to be identified. Again, the greater auricular nerve, the steps remain the same. We'll be having more discussion, I'm sure, with Dr. Shilpi. You can see again the main trunk and the upper and lower main divisions, and the tumor being segregated. But some of these branches are running directly into the tumor. We have been able to preserve the upper trunk, and therefore the eye closure part is taken care of. And this is the lower division, and then it's going into the tumor. And then if it is like that, then definitely we need to sacrifice it. And there is no harm because we have already taken permission from the patient for the same. We also took a part of the masseter and also did the neck dissection clearance along with that. And this is another picture of a similar patient, different patient, which showed a cable grafting, which can be done in the same setting. And final report of the patient, which I mentioned, was a high-grade leukoepidermoid carcinoma with neck nodes also positive, and patient received adjunctive radiotherapy in postoperative period. Extended radical paratradectomy needs to be done occasionally, as I mentioned. And now this is a patient who had a right parotid mass, a 6 by 8 centimeter mass, and the Milan category was 4B. It was suspicious of a malignancy. Intraoperative frozen section was also suspicious of malignancy with the skin involvement. So it was a large mass. Again, we do come across these kinds of patients, as I mentioned. Here also we have to identify, we did the same thing, identified the main trunk of the facial nerve and try to preserve as much as we can. But sometimes it goes directly into the tumor and then we need to sacrifice that. But we had an adequate disease clearance on table along with the neck dissection. And we also rotated the sternocleidomastoid muscle too, so that the hollow, which is created posterior to the angle of the mandible, is avoided. But finally, it was reported as a diffuse B-cell lymphoma, and patient received CHOP regime for the same. There's another patient where we had done for an adenoid cystic carcinoma, and then finally we had used a pectoralis major myocutaneous flap for good cosmetic results otherwise. Yet yes, after resection, what is important is roll of frozen section on table. If you have a good cytopathology team and histopathology team, they can definitely help you to tell whether it's a benign or a malignant lesion. Similarly, whether it's an N0 or N+ neck is important for all of us. Adequacy of paratradectomy is important even in cases of benign lesions, especially because you have the facial nerve close by. And for pleomorphic adenoma, you take as much of a margin as possible of the normal parotid tissue also. And we are generally trained as ENT surgeons. You can use the microscope for facial nerve end-to-end anastomosis or cable grafting. And the one which is easily available is the greater auricular nerve, which is straight away available. You can use that. And if you have seen, the bore of the greater auricular nerve is almost equivalent to the main trunk also. So it's a very good nerve to use. And skin closure, generally a good scar comes up, but sometimes if the skin is also involved, then you might have to require some local pedicle or free flaps, as the case may be. Frey syndrome can be avoided if you have a thicker flap, and definitely this SMAS helps us to prevent that kind. But occasionally troublesome, if it is troubling you, then maybe Gore-Tex or some fascia might be needed to be interposed as a surgical procedure. But usually nothing else is required. Reassurance is more than adequate. Facial nerve injury is what everybody is more worried about. Temporary paresis occurring about 10 to 50% is usually because of neuropraxia. And it recovers in most of the cases, not to worry much about it. Permanent only in 0 to 5% of cases. And as I said, most of them are usually those with malignancies. Hematoma, sernomas, Frey syndrome, and all are often mentioned. This is the post-operative management only, as I said, for malignancies. Usually you'd have to consider all that. Otherwise, for benign tumors, adequate margin, adequate excision. But these patients still need to be under follow-up. As I mentioned, the histology is very varied. You will have occasional pleomorphic adenomas, which are very aggressive also, and some adenoid cystic carcinomas or mucoepidermoid, which are very indolent. So keep these patients on follow-up, and I think we can provide them with the best services. So thank you very much. I've tried to be brief. I'm open to any questions. Thank you, Dr. Vipin. Thank you, respected chairperson, sir, Professor Saurabh Varshney. So if there are any questions, Professor Saurabh?
Thank you, Dr. Nitin, for such a nice, lucid presentation. I have comment the usual story which is there in Parotid is young on FNAC pleomorphic adenoma, and you do a superficial paratectomy, and then histopathology shows low-grade or carcinoma, mucoepidermoid carcinoma. So how do you tackle such cases? You have made a good presentation. It is a lucid and showing total paratectomy, superficial paratectomy, radical and extended radical. So it's a nice presentation, and that is the scenario. So how you deal with such a cases?
Professor Ishwar, thank you very much. I think this dilemma is quite common. I think everybody, all of us have passed through this. And suppose it is a limited lesion, initially you were suspected it as pleomorphic adenoma based on the FNAC. Suppose it is a 3 by 2 centimeter lesion and you remove with an adequate cuff of tissue, finally got reported as suppose mucoepidermal carcinoma, low grade, and patient is willing to come to you for follow-up. I think you have achieved adequate, because as I said, a low grade or an indolent mucoepidermal carcinoma, but should be kept on follow-up, of course. Then your problem is possibly sorted out. Then patient may not require immediate surgery. But if there is a chance of recurrence, then this patient needs to be subjected. But if this patient has a high grade or an intermediate grade, patient cannot come for follow-up, then I think it is better to go ahead with a total conservative paratradectomy and radiation, as the case may be, finally after you get your histopathology in the end. But I think we'll have this discussion when Dr. Shilpi also.
Yeah, Dr. Shilpi sent a remark.
I'm sure she would be having this type of a discussion lined up already. But yes, it's the histopathology. I think again and again, I would like to emphasize that they are the ones who will give us the clue as to how to manage our patients.
Nitin, I recently operated an infiltrating lipoma.
Yes.
And it was quite, the nerve was so thick, very, almost double the size of what we normally see. So there was hyperplasia, and lipoma was infiltrating into the gland. And it was 8-hour surgery which lasted. And I was not able to remove the whole lipoma. It was a partial. Then in the end, I had to finish up the surgery. I had a tough time in infiltrating lipoma.
It's very surprising that some of the benign tumors in the parotid region are actually more difficult at times, whether we are talking of hemangiomas, which are also infiltrating not only to the parotid walls, also into the muscle and surrounding areas. Lipomas, we still have a patient in our ward, like you just mentioned, a girl who has a large lipomatous type of a lesion. So lipomas, hemangiomas, which are infiltrating into that area, also into the masseter muscle, actually more difficult because you really won't know how much of tissue to remove further on. There are so many vital structures as well. But otherwise, yes, if it's a malignancy or a clear-cut pleomorphic adenoma, it's much more easier. Plus, there are adjuvant therapies that you can give in malignancies, which unfortunately, most of the benign tumors, it's left to the surgical resection part, and it's the form and the function also which needs to be taken care of. So yes, it's always challenging. And these are usually, many of these are pediatric patients. So you have to really sit and explain to the patient, or patient has to undergo staged surgery also at times. Sir.
I think we can, if no other comment or question, we can ask the Dr. Shilpi to start our panel. Dr. Vipin.
Thank you, sir, for an excellent presentation. You have summarized such a wide variety of cases in a very short and crisp presentation. So thank you very much. And for the next session, before we begin the next session, I would, Dr. Shilpi, can you please stop sharing?
I'm so sorry. Okay.
Just give me a minute.
Sure.
Yeah, thank you. I would request our president, Dr. H.C. Taneja, to present token of appreciation to Professor Nitin Nagarkar for this presentation. And I would request Dr. Taneja to read this.
Thank you, Vipin. Association of Otolaryngologists of India, Delhi State presents certificate of appreciation to Professor Nitin M. Nagarkar, Director, AIIMS Raipur and AIIMS Bhopal, for delivering national invited lecture on surgical management of parotid tumors, April the 6th, 2022. Signed by Professor Vipin Arora, Dr. Hitesh Verma, and myself, Dr. S. Taneja. Thank you, Dr. Nitin.
Thank you, Professor Taneja.
Date is 9.
Here it is wrongly written 6, I think.
Yeah, I think. So we'll correct it, sir. This certificate will be corrected and
we'll correct it and then we will correct it.
Inadvertent error.
Thank you, sir. Thank you so much, sir.
So we'll frame it and, sir, we'll send it across to your office. And
I'm honored, sir. Thank you, sir.
Thank you so much for joining. And for the next session, sir, I would request you to stay for the panel discussion also.
Sure, of course. Yeah,
and for the next session, we are going to discuss some controversies in the management of salivary cancers. And Dr. Shilpi Sharma, who's a head and neck cancer surgeon at Narayana Hospital, Gurugram, is a moderator for this session. And they are panelists. Dr. Shilpi, would you introduce the panelists?
Yeah, so we have Dr. Nitin Nagarkar, who has already been introduced. We have Dr. Uma Garg, who is also a surgeon. We have Dr. Pallavi Kaul, Dr. Sangeet Agarwal, and Dr. Vishal Gupta. And we have one radiation oncologist amongst the panelists, Dr. Pragya Shukla. And would you like to introduce them in detail? Because I don't have time.
Yeah, Dr. Uma Garg is a professor and head at Government Medical College, Sonipat. And Dr. Pragya Shukla is a radiation oncologist and my colleague at Delhi State Cancer Institute. And Dr. Pallavi Kaul is a very talented young head and neck surgeon from Dehradun. And Dr. Sangeet Agarwal. Dr. Sangeet is here?
Yes, sir. I'm here.
Dr. Sangeet is a head and neck surgeon at Sir Gangaram Hospital, New Delhi. And Dr. Vishal Gupta is a head and neck surgeon at Rouseville Park Comprehensive Cancer Center, Buffalo, New York. So you have a very illustrious panel and very well-read and very knowledgeable moderator, Dr. Shilpi Sharma. So I would request you to start your presentation, Dr. Shilpi. Thank you.
So is it audible?
Yes.
And is it visible, the screen?
Yes, it is visible.
Okay, so first of all, thank you very much, Dr. Vipin and the whole organizing team for having me here and giving this opportunity. And let us discuss a few cases as the time permits. So I'm not able to. So let's start with the first case. She's a 26-year-old lady who presented with the right-sided neck swelling of 18 months duration. As we can see, it's about 3 centimeter by 2.5 centimeter in the infraauricular region. On palpation, it is cystic. There is no intraoral bulge, no other palpable lymph nodes, and facial nerve functions are normal. So I would ask Dr. Pallavi, how would you proceed further? What would be the investigation which you would be doing next? Dr. Pallavi?
Am I audible?
Yes, yes.
Good evening, everyone. Dr. Vipin, thank you for your kind introduction. And hello, everyone. So for this particular case, as we can see, this is the female patient. The clinical history.
Just tell me the next line of investigation, because we have 4 or 5 cases and we don't have much time.
First investigation of choice for this particular patient would be an ultrasonography. So based on my ultrasonography findings, I would further proceed whether to go for an MRI scan or a CT scan if needed. So primarily the ultrasound scanning would be the first modality. Also,
can't we do the MRI first?
Since you mentioned specifically that the patient does not have any intraoral bulge and the size of the tumor, and based on the history, it looks like more so of a superficial tumor. So I think ultrasound would suffice. If I have any doubt that there is extension of the tumor going into deep lobe, I would offer MRI to the patient.
Dr. Nitin, do you agree with her or would you like to do something else?
Yeah, thank you, madam. I think, yes, different ways of managing the same thing. In many places, an MRI may not be instantly available. But I think, yes, if an MRI is available, it will tell us, because we are not able to exactly tell what is the deep extent of the tumor. We can do an MRI and then follow it up with an FNAC, because sometimes an FNAC might actually alter the MRI picture occasionally. Not always, but yes. So we can perform an MRI, get an idea, and then go ahead with this with an FNAC. We know which areas to actually pick up the solid area.
Yeah, so I agree with you, though she's also right, and ultrasound can be an initial choice of investigation, but somehow because it's a large tumor and we would like to be more sure about the extent, though even though it is not an intraoral, well, there is no gross deep lobe involvement, but yes, in a large this kind of scenario, even MRI would be slightly preferred, but yes, you can do ultrasound first. If you go through the NCCN guidelines, they actually do not even mention the ultrasound in the initial workup of a salivary gland swelling, because more often than you really actually have to kind of end up doing MRI. So we also did MRI for this lady, and we found that there is a cystic solid lesion arising from the lower pole of the superficial lobe of the parotid. Now, Dr. Sangeet, what would you do next?
I will do ultrasound guided FNAC first, because
Okay,
ultrasound
great.
guided, yes, I will go for especially ultrasound guided, because this is a solid
Great.
cystic lesion. So I will go
Yes.
for ultrasound guided FNAC. Yeah.
And would you also instruct your radiologist to do something at the time of when they are taking the FNAC from this kind of lesion?
Yes, obviously, I will convey to my radiologist as a please go from solid part also.
Yes. So that is very important, because sometimes though we are all trained, but sometimes it happens that someone might not be aware and they can just make the smear from the cervical fluid. So it is very important to visualize the solid area and take the FNAC from that portion. So we also did the same. We did ultrasound guided FNAC, and we found that salivary, it is a sump or salivary gland neoplasm of uncertain malignant potential. So my question to you, Dr. Uma, what would you do next, ma'am?
I think now we can plan the surgery. Can you hear me?
Yes,
am I audible?
We can.
So we
yes,
can
ma'am.
Plan the surgery. We've done USG. We have done MRI and ultrasound guided FNAC also. So we'll have to go for surgery now.
Yes, very rightly, like ma'am mentioned that this sump is actually 4B category as per the Milan system of classification. For those who are not aware of this classification, it's basically similar to what we do in thyroid, like we have Bethesda. So they have defined the categories, 6 categories, and they have also predicted the risk of malignancy. And since our patient belong to this T4B category, the risk of malignancy is 35%. So yes, we would counsel the patient for the surgery. Now, next question to you, Dr. Vishal. So what would be the extent of surgery in this patient? So she's a young patient. We don't know whether it is benign or malignant. And how do you decide that what kind of surgery we should offer to her? Dr. Vishal?
Sorry, I was on mute. Yeah, so basically I will look at MRI or CT scan images. That can give you some idea about location of the tumor. It's superficial, looking at the photograph and MRI, but you can look at the relationship to the retromandibular vein.
So it is a superficial lesion arising from the tail of the parotid gland, but it is about 4 by 3 centimeter.
So I'll go for I will do a superficial parotidectomy for this patient.
Okay. So, Dr. Nitin, any role of frozen section in this kind of scenario? Would you like to, if you have the facility, would you like to go for that?
I think yes, it is. If you can have your pathologist, you've informed them prior, you've discussed with them, because you know what you exactly want to know. There are times when they can tell you the margin better, but because you're not actually giving a capsule as such, but if you have removed a part of the tumor, then it's another thing, or you've given the entire tumor to them, and then you wait for half an hour or whatever till they give you the report. But the accuracy of frozen section is not so much. You have to develop a good team, and if you've got a team which is reliable enough, because I think that will make a lot of difference on the table. Because suppose this is reported as a malignancy, then you would possibly like to go for a total conservative parotidectomy then in that case. If it is going to be reported as a benign tumor, then I think whatever was done, the superficial parotidectomy would have sufficed.
Yes, I also kind of agree with you. I would also like to avail the facility because as per the literature also, or in our experience also, it is a good tool to differentiate between a benign and malignant. It may not further subtype the type of malignancy, but yes, it can broadly tell you. However, in this case, because it's a cystic lesion, the solid part is not much. There may be a sampling error and it may not be as accurate. So we must keep that point also in mind. So this patient, somehow frozen section was favorably benign, but they were not sure whether it was malignant or no. Patient underwent superficial parotidectomy, and final HPR was intermediate grade mucoepidermoid carcinoma. It was 1.5 by 1 centimeter. There was no lymphovascular PNI. Margins are adequate. Now, before I go to the further management of this type, let's discuss what do we mean by margins in salivary gland cancer. So, Dr. Pallavi, would you please throw some light? Is it same as we have in oral cancers, or it is something different?
With the evidence, we can take there is a proposal for adequate parotidectomy concept.
So just describe the margin. How do you decide involved? How do you say when that is adequate? What is the size cutoff? Or anyone else can take this question. Maybe Dr. Sangeet, you can talk about it.
Yeah. Actually, what I am doing here is that basically all the tumors, most commonly they are well defined tumors. So it is based on our intra-operative findings that how are the planes. So we take usually at least 1 to 1.5 centimeter of the cuff if it is possible, and basically low
that
grade.
Is fine. That we are talking about adequate parotidectomy. I am asking you, when we have the HPR report, you have done the superficial parotidectomy, and what exactly would you look at the margins in that scenario, or would you kind of give any importance while deciding for the further therapy?
So basically for further therapy, I will see the grade of the tumor. Means if it is low grade or intermediate grade, I am fine with my margins if they are uninvolved. And the tumor behavior, means the LVI and PNI.
Yeah, so just in very few points about the margins. So in salivary gland cancer, there are, though not kind of clear-cut definitions, but majority of the literature, they are in favor of, again, they divide it into positive or involved or close. And there's also some entity like close but clear margin. So positive, like we can guess that it's microscopic residual disease, or there is tumor cells margin. But one important thing which has been incorporated as a positive margin is the intraoperative, like Dr. Sangeet mentioned, that if you have to peel off the tumor from the facial nerve, probably that you are not going to get very good margin over there, which may not be mentioned in histopathology. But when you're deciding for adjuvant therapy, you have to keep that point in mind. Close margin again is defined as less than 5 millimeter margin. There is also some entity described in the literature as close but clear. So margin may be less than 5 millimeter. It may be 1 millimeter or 2 millimeter, but the surgeon is sure that he did not peel off the tumor from the facial nerve. So he's kind of more, relaxed that, okay, the margin was closed, but my facial nerve was intact and it was a clear margin. So they call it a complete removal of tumor with uninvolved functional nerve is preserved. So coming back to our histopath, now we know that we are dealing with intermediate grade mucoepidermoid carcinoma. So again, points. Dr. Vishal, maybe you can say, what would you do next? Would you observe this patient? Will you go in and do the completion, or will you just send it for radiation therapy?
Yeah, so there are two grading systems. There is one called Brandywine grading system, and there is AFIP grading system. So Brandywine system, so called upgrades the intermediate grade. If your pathologist using a Brandywine system and call it intermediate grade, usually I would like to go for it. But if they use AFIP system, which usually then I would use, it depends on the grading system. But if you don't know about it, there's no just have a discussion with the patients. You can go for adjuvant radiation treatment. So you just have to have a discussion with the patient.
Yes. So you raised a very important point that it's not that intermediate grade or high grade, they are same. Yes, low grade, there is no debate. We can actually observe this is nice. Low grade, we have guidelines and support our favor that if you have a low grade, small tumors, even if you have done less than superficial parotidectomy, but you have nice 1.5 centimeter, you may safely observe. But here we are talking about a patient who is intermediate grade. But intermediate grade, like you pointed out, is not always same as high grade. And in fact, this is the table taken from the latest ESCO guidelines published in 2021. And as per this table, you can see actually the intermediate grade mucoepidermoid carcinoma has been clubbed together with the less aggressive variety of the patient. So my question to you, Dr. Pragya, because you are the radiation oncologist, finally you will have the word. So would you like to radiate this patient, or you can keep this patient under the observation?
I would like to take, because she's a young female, I would like to keep her under observation, because the intermediate grade is a less aggressive kind of thing. And if it depends, Shilpi, if the person is not in a position to come for follow-up, regular follow-up, we have to see the whole thing. But in ideal circumstances, I would like to keep her under observation.
Now, similar scenario coming to the next case, similar kind of picture, 30-year-old young girl, small lesion, FNAC suggestive of benign tumor, underwent superficial parotidectomy, and now the histopathology is low-grade mucoepidermoid carcinoma, T2, not T1, but the margins are closed, though there are no other adverse factors. Will that change anything, Dr. Pragya?
With closed margins, I would definitely want to give radiotherapy. Even though it is low grade, but the margins are closed, I would not like to take a risk in this female. Yeah.
Okay. Dr. Nitin, Dr. Vishal, Dr. Pallavi, Dr. Uma, any difference in opinion? Would you all like to irradiate this patient?
I will observe
I
it.
will like to keep her.
I will observe.
Observation.
I will observe.
I will give radiation, I think, considering the closed margins, that's one. Of course, it's low grade. The problem is resurgery is always more difficult in these kinds of cases, definitely because of the facial nerve involvement. And rather, we know that patient has got a mucoepidermoid carcinoma, low grade, but closed margins. So I think we have not actually entirely satisfied with the therapy that we are doing. But as I said, there is nothing hard and fast about it. The patient can come regularly for follow-up, you still have an option. I would be safer by giving
so there is
radiotherapy.
So this is really controversial. Controversial topic. Yes, Dr. Sangeet.
Shilpi, I will say one thing.
Yeah.
Again, I will think about my intraoperative findings. If I am
intraoperative findings, it's close but clear.
Yeah. So that's my point. If I am quite satisfied that I have not leaved any major gross disease, or I have taken tumor whole out, either I am not taking the adequate parotid tissue, and there is no other adverse features, and it is low grade, I will observe the patient. I will observe.
So this is really controversial topic, controversial points. Like we see, there is difference in opinion amongst our esteemed panelists also. If you look at the NCCA guidelines, they broadly say if you have got, even if completely resected, but if you have closed the positive margin, radiotherapy is preferred. They also don't say that you have to give, but yes, it is preferred. However, we also look at the literature, though not large series, but yes, there are few studies. One of them have been quoted. So here they included low-grade mucoepidermoid carcinomas with positive and closed margins. They divided, but of course it was a retrospective study, and they observed all the closed margins, and they saw that the recurrence rate and recurrence-free survival was similar to the patients with positive margin who underwent some kind of intervention. Whether you do revision surgery, whether you give radiotherapy, whether you do revision surgery plus radiotherapy, closed margins still can be observed. So both the things can be done. Now, since we are discussing radiation therapy, Pragya, could you please tell us what are the indications of radiotherapy in salivary gland cancers?
So before answering your question, Shilpi, I would like to ask the panel why they are so averse giving radiation. You know, in our situation, in our country, keeping patients under close observation is a difficult task.
So that's why you have to choose. If your patient is willing for complete follow-up, patient is young, maybe she doesn't want to undergo radiotherapy. Radiotherapy is an additional cancer modality.
No, I want to address the concerns of the panel,
of course,
why they don't want to go for radiotherapy.
Okay, maybe Dr. Uma or Dr. Sangeet, you can answer as you wanted to answer.
Yeah,
yes,
because the patient is young. because the patient is young and therefore the problems after radiotherapy ought to be there. So for whatever time we can save the patient from those side effects, I think we can observe intensively and wait for it.
So that is why I wanted to hear that word, the adverse effects of radiotherapy. Ma'am, very humbly, I would like to disagree. Radiation has evolved a lot over the centuries. Now with the newer modalities, we don't get to see that kind of ill effects and the harmful effects that we had in the past when cobalt was there. With conformal radiation and image-guided radiotherapy, we don't see those side effects. So what I see and more so as an oncologist, Shilpi, whatever we are getting chance, the first chance is the best chance. Rather than waiting for the tumor to come back to us with vengeance, I would like to give my best upfront. So I wanted to hear
about low grade. They are not very aggressive kind of.
I'm not talking about grade.
I am a surgeon. You're the only radiation oncologist, but you ask any of the surgeon, it's not that radiation therapy is without side effects. Even in the, whether you use IMRT, IGRT, there are some side effects. There are going to be some permanent as well.
And that cannot be managed.
Get married, it matters.
They are
Pragya, I will say pleomorphic adenomas and low-grade mucoepidermoid carcinomas, they have almost same behavior. So basically, if in such a condition, if you consider as a pleomorphic adenoma with the close margins, I will say this low-grade mucoepidermoid behaves almost same with the pleomorphic adenoma. So I will observe it.
I'm sorry to interrupt. Shilpi. I'm sorry to interrupt. There's a lot of background noise. So can everybody except for the panelist go on the mute mode? Please mute yourself. Yeah, there's a lot of background noise. Please mute yourself, and only the panelist and the moderator, they should unmute. Thank you.
See, what I feel, I agree with the concern about.
We will just move forward because we don't have much time. And point well taken. We should not push the patient for in either of the direction. Both the options observed are there. We should present this to the patient. If we feel slightly patient is not willing to take that chance, then yes, please give adjuvant radiation. But we should make this. But is also there.
But Shilpi, that is what I want to put across. These things what you are asking me can be very well read in the books and the literature. But what I want to tell you all is that aversion for toxicity of radiotherapy, it is not as high. The toxicity is not as high.
It is not as high, but it is there.
Yeah.
So quickly just go through the indications of radiation.
Radiotherapy is high grade. We all know T3, T4 disease, extracapsular involvement, close margins or positive margins, PNI. All these things are the indications where radiotherapy is frankly to be considered.
Yes. So if in one line or two line, if we have to summarize, my teacher always used to say that it's difficult to remember, especially when you're a resident and you have to say in exams. So just remember that all except T1, T2 low grade without any other adverse feature, and of course they should be node negative. All others they require, whether it is PNI, LV, whether it is a recurrent tumor, whether it is a high grade or with node positive. So let's go on to the next case. So this was a 55-year-old male who underwent white excision of an upper lid lesion by ophthalmologist. Histopathology report was squamous cell carcinoma. It was a T1, very well excised. All the margins were more than 1 centimeter. And then after 2 months, he noticed a small swelling on right side of the neck. And then he came to us. And we found, as you can see here, that there was swelling in the infra-auricular region. It was firm to hard. It could be tail parotid. It could be level 2 lymph nodes. Facial nerve functions were normal. He underwent ultrasound because we wanted to send for the FNAC. He was very apprehensive. So at the same time, we also did ultrasound of the neck. There was a hypoechoic lymph node in the superficial lobe. and the size was 1.9 by 0.9 centimeter, and there were one or two right level 2 lymph nodes as well, which were enlarged. However, ultrasound guided FNAC came out to be ciliadenosis. Patient was happy, but I was not happy. So, Dr. Vishal, what would you do next? Would you do any other investigation? Would you repeat ultrasound guided FNA or something else?
Yeah, so we do like a core biopsy. So I will either repeat the core biopsy or talk to the patient, say, this doesn't look right. There is a margin of error with FNA, and it will be really bad to miss out on a metastatic cancer. So I will either repeat the core biopsy or take the consent for total parotidectomy, neck dissection, take the patient to the operating room and remove this mass, send for frozen, confirm it's not a malignancy, and then go from there.
Very well said. So we also did the same because it must be remembered, though FNAC is very good in differentiating benign from malignant, but yes, it has its own percentage of error. If your clinical suspicion says that it is going to be a cancer, then definitely do the core biopsy. And in this patient also, this came out to be a metastatic, poorly differentiated carcinoma. Though the initial histopathology report of the lid lesion said it is squamous, but our pathologists were not sure. They did not see any squamous this thing. Even after doing ISC, they were not sure. They suspected it could be some high-grade sebaceous or some apocrine carcinoma variant. So before taking up for surgery, we did PET-CT, and PET-CT showed 4 FDG centimeter size of lymph nodes in the parotid space. There were no neck nodes, no distal metastasis. Of course, everybody would do surgery. Now, what I want to ask is what would be the extent of the surgery? Anyone can answer, or maybe Dr. Pallav, we have been quiet for some time. So for the primary, let's start with the primary. What you would do? Would you do superficial parotidectomy or would you do total parotidectomy?
I would like to know where the location based on your PET scan.
It's in the parotid space. It's in the parotid space. So parotid space, it could be in the superficial lobe, it could be in the deep lobe.
So,
and there are 4, small but 4.
And all the 4 nodes are located in the superficial lobe.
So that we don't know. So they said that it is in the parotid space, but most likely they said it's in the superficial.
So if they are confined, we know that the majority of lymph nodes are located in the superficial lobe. So I'll go for a superficial parotidectomy.
Okay. What is the opinion of others? So let's discuss about superficial and total. That's all. So Dr. Uma, what would you do, ma'am?
I would go for total parotidectomy.
Okay, one for superficial, one for total. Dr. Sheetal,
Actually,
Dr. Nitin, Dr. Vishal.
I think I'll go for a total parotidectomy, but preserve the facial nerve definitely, all the branches.
Yeah. Actually, Shilpi, what is actually there is nothing like total and superficial parotidectomy. Basically, we will do clearance as much as possible by preserving the facial nerve. So this
is not like that. You have these are Dr. Nitin took some such nice lecture. They elaborated in details what is superficial, what is total conservative, what is
actually
total.
You can't remove each and every.
So when you say you are doing total, you mean to say that you will not stop at facial nerve. You will include superficial. You will take the deep lobe also. But as we all know that sometimes there is some apprehension that if you do total parotidectomy, there may be marginal mandibular paresis, risk is there and all. So that is the question. Should we do total parotidectomy in metastatic carcinoma to the parotid, or can we avoid it?
I think because we're not sure about the extent of how many lymph nodes there are.
So they're in the 4. They're mainly in the superficial lobe.
Mainly in the superficial. So I think, okay, then we can do a superficial parotidectomy. But along with that, of course, neck dissection, that point.
Yeah, that we will discuss later.
That we'll discuss. But I think if we are safe that we have removed all those 4 nodes, then it is fine. Anyway, the patient will receive adjuvant therapy subsequently. So I think that's important.
Yeah, so again, the literature is divided. Of course, we all know that we don't have large series, we don't have randomized trials in salivary gland carcinoma. The evidence comes from the retrospective data. This is one study where they had studied the eyelid carcinoma specifically, which had gone to the parotid, and they found that though the numbers were small, but they found those patients who underwent superficial parotidectomy, they had recurrence, while all 5 patients, they did not have any local parotid recurrence when the total parotidectomy was performed. Similarly, this is another study, larger patient, and they had included cutaneous squamous cell carcinoma as well as malignant melanoma. And they also, they found that when you remove the deep lobe, it's better because the control which you achieve after doing superficial plus deep, despite giving radiotherapy, is better when you do only superficial plus radiation therapy. So we do have some evidence, but like Dr. mentioned, this is data which included around 65 patients who underwent total superficial parotidectomy, 64 received radiation therapy. So almost everyone who received superficial parotidectomy also received radiation therapy, and the survival control was very good. And in fact, the parotid bed recurrence rate was very small, only 3.7% when the patient has received RT. So yes, it may not be necessary in all. So if you are planning to give radiation therapy, if you are much worried about marginal paresis, then that can be avoided. That's an option. Or you can do total parotidectomy also, because per se it is not it is an anatomical division. It is not something which is embryologically kind of different. So superficial is we don't do parotidectomy, we are a facial nerve. So that is also an equally valid option. Now coming to the neck management, Dr. Vishal. So what would be the extent of neck dissection in this patient? There are cervical lymph nodes enlarged at level 2 level, but they are not FDG-avid. What would you do?
So this is a clinically and positive and pathologically and positive disease. I will go for a total parotid. I will definitely go for a total parotidectomy and comprehensive neck dissection from level 1 to 5.
Okay. But we don't have any, positive lymph node at level 2. This is the deep superficial parotid lymph node which are positive.
I get it, but this is a clinically positive disease. I usually take, it takes probably like 10 extra minutes to take level 5, and I'd rather have a good sampling of a good sampling of lymph nodes from the neck. I usually go, if there is a clinically positive lymph node, I usually go for a comprehensive.
It is not clinically positive lymph node. It is the tail parotid lymph node which is positive, but yes, not the level 2 or level 3.
I understand that, but it is a metastatic disease into a lymphatic system, and it goes down, like it's coming from eyelid. So, I know there's a controversy about it. Some of my partners will do
okay. You will do 1 to 5, accepted, point well taken. Dr. Nitin?
I think it's a poorly differentiated cancer. It's metastatic. We'll have to remove more HLNs. Nothing wrong in clearing the neck. It will at least help us to label it, and we'll know whether it's positive or negative. It will help us in our future management also for the adjunctive therapy. Yes,
okay. Any difference in opinion, Dr. Uma ma'am, Dr. Pallavi, Dr. Sheetal?
We have data, Dr. Shilpi, we have data from
neck dissection is needed, definitely.
Neck dissection is needed, but what would be the extent? Whether you would do 1 to 5, or you would do 1 to 3, or you would do 2 to 3, what you would do?
Dr. Shilpi, there is data from...
1 to 4.
Yes, Dr. Pallavi?
Yeah, so we have data from MSK-CT study, which shows that in case of N0 nodal station, N0 status of the neck, we can send the level 2 nodes for frozen section. And if the frozen turns out to be positive, we can convert our selective neck dissection into a comprehensive neck dissection in such a scenario where we will have an N0 neck.
Yes, yes. So, of course, we addressed the neck in high grade T3, T4, we all know that. But extent still varies in N0. Even when you are doing high grade, people say that because the first echelon is level 2 lymph nodes. So if level 2 and level 3, they are the most common. So if you're clearing level 2 to 4, it's good enough. You don't have to do level 1 and 5, because in N0 node, it has been seen that the incidence of lymph node metastasis is very low, less than 7%. But when it becomes positive neck, or clinically positive or N positive, then you must do level 1 to 5. So yes, that is very good option, and that's what we did. We sampled level 2 and level 3, send it for the frozen section, and frozen sections were negative. So we did not clear level 1 and 4 and 5. We did total conservative paratradectomy and level 2 to 3 lymph node clearance. And this was the pathology. It was a poorly differentiated metastatic carcinoma. Only one intraparietal lymph node was involved, but there was focal ENE, and all 16 lymph nodes from level 2 and 3 were negative. So my question to you, Dr. Pragya. So of course, he will require adjuvant treatment, but what kind of treatment, since like in oral cancer, when you have ENE, you add chemotherapy. Is it the same in salivary cancers as well?
Yeah, we do add chemotherapy if there is ENE in salivary gland tumors, and the level that we will go in the node in the next side we'll go, because it's just one lymph node that has come out positive. It is node positive from radiation point of view. So we will be going up to level 4 for radiation. We'll be addressing the ipsilateral side of the neck. And
okay, before we discuss the extent, we don't have any medical oncologists in our group, but I would like to take the opinion of other panelists. Would you add chemotherapy to this patient?
Dr. Shilpi, we do not have any
as concurrent
supporting.
Yeah, as a concurrent.
Yeah, we will.
Dr.
Is there any data that chemotherapy should be given in concurrent setting? Because as far as I also try to search the literature to, kind of support this, but they say outside the clinical trial, routinely it is not given because they are not very, chemosensitive, and radiation therapy is good enough. But I would be happy to know your point of view.
I will share a study with you, Shilpi, later on, where they have categorically mentioned if it is a pathological extranodal extension, then we will definitely be giving concurrent chemotherapy.
In salivary gland cancers?
I think even I'll agree.
So there are 3.
And how many patients were there?
So that I will share the entire thing. I will share. It is like gross residual in unresectable. These 3-4 indications are there.
Yeah, so that's what. So we are not talking about gross unresectable. We are talking about a patient.
No, amongst the indication for concurrent chemotherapy in salivary gland, yes, they are not very responsive, but 3-4 indications are there in which this extranodal extension does come, in which concurrent chemo has to be given along with radiotherapy. I'll share that study with you.
Yeah, but there are some studies going on.
Yeah.
RTOG 1008 study.
They are going on, yes.
A report in due course for chemo and radiation. I do agree that in many cases it's still being given, but the role has not been so clear-cut yet. So let's wait for that evidence. We don't have that level 1 evidence for chemotherapy for these kinds of salivary gland tumors. Although in such cases, ENE positive, definitely some centers are giving it.
So it's again a gray area. Yeah, mostly when you just have focal ENE, well resected, not just one lymph node, there is not a clear-cut indication of adding chemotherapy. And if you look at the ESCO guidelines, and or even like we saw in NCCN, they also say it may be given. So these are the gray area where you really have to discuss with medical oncologists. You have to see the patient as a whole, then you decide. So now coming back to the extent of radiation therapy. So there is one point about this case, Dr. Pragya. So this patient underwent a primary excision of the eyelid. And then after 2 months, he came to us. And then there was the issue with the FNACs, and then he underwent, made up mind. Then we did core biopsy and surgery, and et cetera. So now he's 3 months plus. So when you are giving radiation therapy, would you include the eye as well? Or you will include eye plus parotid and also the neck? Or you will just do parotid plus neck? Considering that when you give radiation to the eye, it has its own, effects. So what would you do, and how effective it would be now? And it's a common scenario. Patients sometimes they are operated for something at that time. These are not addressed, and then they develop it later. But this is a gray zone, this 3 months. So what you would do?
Shilpi, literature clearly shows that the entire duration, between surgery and radiotherapy, if it exceeds 60 days, 2 months, so the benefit of the adjuvant radiotherapy declines. Okay, so having said that, I'm a proponent of the first chance is the best chance. So I usually go in a very aggressive way. So eyelid tumor per se, we can always have electrons to use to treat that. And because it is superficial, the side effects, I would quote and unquote, are not as much as people fear. So I would be aggressive, but it will depend case to case basis, depending on the, the tolerability, the GC, everything of that patient. But in ideal situations, circumstances, yes, I would.
Okay. So one more thing which I wanted to share with us, that is proton, like we say that proton therapy is good for salivary gland carcinoma and all. Is there real benefit of adding proton therapy in place of photon normal, what we give in normal circumstances? Forget this case or any other case. Suppose you have a patient, you want to either treat, whether it is adjuvant or concurrent or whatever. Do you think that if you have the facility, you will prefer proton over this normal conventional therapy?
Yeah. Proton has shown reasonable benefits in terms of toxicity for such kind of tumors, because the black peak, the sharp black peak avoids the distribution of radiation to the nearby normal tissue, drastically cut down. So for such tumors, proton is beneficial. I will not say in terms of control or tumor control or other things, but yes, in terms of toxicity.
But control would be the same. It is not beneficial in terms of improving.
Yeah. The proton doesn't do much. Like, no, the control doesn't go that, there's not that change. It is more of the toxicity that we are cutting down upon.
Okay. So Dr. Vipin, do we have time?
I would like to add one more thing, Shilpi, because we cut down the toxicity, we have a chance of dose escalation, like, no, in general terms I'm talking about with proton. So if we are able to escalate the dose, definitely we are going for more tumor control.
Yeah, so that's why it is very helpful in inoperable tumors or gross residual disease, because we can achieve.
That helps.
Yeah, but if you look at actually,
and even for positive margins. So when we are in a condition to escalate the dose. So without increase in toxicity. So that does help us there. Yeah, it does.
If you look at the guidelines, they say it's not added advantage in terms of oncological control. So you don't have to push for it. It is equal in terms of oncological control. That point we must be, we must remember that in adjuvant setting, oncological control, I think that advantage is not there with proton.
No, but
Dr. Vipin, do we have time or should we go on to the next case?
It's a very interesting topic and we can continue on and on, but I would request you to please wind up.
I do agree. More time.
Yeah, that's what. So maybe we can ask our panelists if they just want to give one message, one tip, important tip to all our participants, which they would be happy to take home. We can start with Uma ma'am.
I think because first thing is salivary gland cancers are not that common. Whatever studies we have got are retrospective, and many of the times they are slow growing and indolent. FNAC is not that conclusive. So if you ask me, I'll hardly ever be aggressive on treating the tumors. And so we should be basically evaluating them properly and then decide. That is the take-home message I can.
Dr. Nitin?
I think, thank you very much. A very well conducted, I think, program. Very true that it has very diverse presentations. You have to have a very good discussion with your radiologist, with your pathologist, and maybe, of course, the radiotherapy specialist, because you see, finally, the treatment would depend upon what is the available facility in your particular center. Many of these tumors that we discussed are relatively quite rare. On the contrary, pleomorphic adenoma is much more commoner. So I think only in these rarer tumors, we might have some confusion. Otherwise, I think the plan of action is pretty crystal clear and it's very well laid out in most of the guidelines. So
Dr. Pallavi? Yeah, thank you, sir. You are muted, I guess. We can't hear you, Dr. Pallavi.
So Dr. Shilpi, I just want to add one point regarding radiotherapy. So since regarding that case, since the patient had a low-grade tumor, so it's always better to avoid radiotherapy, especially when dealing with a young patient, because
that is very debatable. So we had a long discussion, but just one tip for our so you should be open-minded. You should have both the options. You should not just push in for any other aggressive. Dr. Sheetal, thanks. Dr. Sheetal.
Sangeet. Dr. Sangeet.
Yeah. I'm so sorry, Dr. Sangeet. I'm so
Dr.
sorry.
Sangeet, yes, I totally agree with Dr. Uma ma'am. In especially in the parotid malignancies, especially for low grade or intermediate grade, we should not very aggressive, as the facial nerve is very important, and we should not very aggressive in low grade or intermediate grade. But definitely, yes, some tumors are very aggressive. So in those cases, we should be aggressive.
Dr. Vishal.
Yeah, I think all the good point has been already said. I just want to add one more point. You know, it's a devastating complication to have to sacrifice someone's facial nerve. And usually at Roswell Park, we do something called like mesenteric nerve to a facial nerve anastomosis, or a deep temporal nerve to a facial branch anastomosis. So I think it's good to become familiar with the anatomical landmarks for mesenteric nerve or a deep temporal nerve. They can really help patients out. You can just do the reconstruction right there. There's very less morbidity to it. So that's all. I just wanted to add a little more point.
Yeah, thank you, Dr. Pragya.
Yeah, it's just that don't be afraid of radiotherapy. It's not that bad.
Yeah. So I just want to add one point, because that was my first next case, but we didn't have time to discuss. When you are doing redo surgery, and when you have to do, because there is a considerable amount of superficial lobe is left behind and all. So if the preoperatively your facial nerve is intact, especially in redo surgery, it applies to all the cases. You should be, make an attempt to preserve it throughout this thing. You may have to peel off the tumor from the facial nerve, but do it, because sometimes in redo, like happened in that case, I was damn sure that I'm going through the disease, but because it was a preoperative function nerve, I peeled off the disease thinking that radiation therapy will take care. And surprisingly, the histopathology, the margins were 2 millimeters. So maybe it was not the disease which I was, peeling off from the facial nerve. It was the fibrosis of the surgery. So the point very well taken, which Dr. Vishal also mentioned, if you're preoperatively, your functional nerve, facial nerve is intact, make all attempt to preserve it. Of course, when it is not encased by the tumor totally. Yes. With that, I think we end our session, and thank you very much.
Facial nerve monitor in that case.
Yes, if you have the facility, then definitely it will be helpful.
Yeah.
Thank you, Dr. Shilpi. I think I just also want to add one comment. I have been itching
please.
to talk, but somehow I am supposed to not to participate directly in the discussion. So if the patient has come to you with an intact facial nerve, patient should be able to go back with an intact facial nerve and do whatever you feel like you want. As you just said, that you peel off the tumor from the nerve, or you maybe even with a gauze, or but try to remove the gross tumor from the facial nerve. And the morbidity of a sacrificed facial nerve is much more than the survival benefit, if at all you have from sacrificing that facial. So morbidity overweighs the concerns for survival. So that is what I wanted to add.
Definitely, and we have evidence also. We have good number of studies which say that if you give radiotherapy and microscopic disease can be taken care of.
Yes. Microscopic disease, radiation is good enough. And with this, I wish to thank our guest speaker today, Professor Nitinam Nagarkar. Thank you, sir, for your participation, and we had such a wonderful lecture from you. And thank you, Dr. Shilpi, for a wonderful moderation. Dr. Uma Garg ma'am, Dr. Vishal, Dr. Sangeet, Dr. Pragya, Dr. Pallavi. And I wish to add our chairpersons, Professor Ishwar Singh, for his moderation of the session 1, and Professor Saurabh Vashne for his moderation. And I just wish to add that Association of Otolaryngologists of India, Delhi State is a 700-member strong body, and we do regularly conduct activities like conferences, hands-on workshops, and other activities for the interest of both the postgraduates as well as for the practicing surgeons. So I invite all the eligible ENT surgeons, even those who are in the training, to become a member of AOI, and we will help you guide through your academic career. We will certainly be able to help you with your academics. And it is also a strong body for advocacy also. And with these comments, I would hand over to our President, Dr. S.C. Taneja, for his closing remarks.
Thank you, Vipin. And this was definitely a very wonderful session, and it covered exhaustively about the salivary gland tumors. And I thank Dr. Nitin for bringing in detail, and definitely this will be helpful for emerging or budding ENT surgeons, and definitely it will be helpful for postgraduate students also. And I thank the moderator, Professor Saurav Varshney, Dr. Ishwar Singh, and moderator Dr. Shilpi, and the panelists. Thank you very much. With this, we close this session.
Yeah, thank you.
Thank you. Wonderful session. Thank you, sir.
Thank you, sir.
Thank you so much.
Thank you, everyone.
Yeah, thanks.